Hello, I'm Dr. Prathima Radhakrishnan. I'm a fetal medicine specialist in Bangalore. I did my MBBS in Government Medical College, Nagpur. Subsequently, I moved to the United Kingdom to specialize in obstetrics and gynecology, where I acquired my MRCOG. Following which, my interest in fetal medicine came up, and I decided to specialize in fetal medicine, which I approached Professor Kypros Nikolaidis in London, and that's where I did my specialization in fetal medicine. So since my return back to India, Bangalore specifically, in 2004, I have been practicing fetal medicine in Bangalore. We have a center in Bangalore called Bangalore Fetal Medicine Center, and our academic wing is the fetal and gynae imaging. And we do a lot of training for gynecologists, obstetricians, and radiologists who want to specialize in fetal medicine. So that's my background. With that, I'm going to take today's topic, which is optimizing fetal outcomes in a routine setting. The aim of antenatal care is to detect congenital anomalies. It could be structural, it could be chromosomal, detect problems with placental insufficiency, which could cause maternal hypertension, and on the fetal side, it can cause fetal growth restriction, and of course, premature delivery and prematurity. And these are the biggest challenges in obstetric and fetal care, contributing largely to the perinatal mortality and morbidity. So we're going to take these things, three things primarily, individually, and see how we can optimize the care for the fetus to be able to deliver with least morbidity and the best outcomes at the end of the pregnancy. So first, let us look at aneuploidies. Now, aneuploidies are basically chromosomal abnormalities. The genes, which are the building blocks, are stored in the chromosomes, and 23 pairs of chromosomes is there in every human being, and they are numbered 1 to 23. Any numerical abnormality, which could be more or less, are known as aneuploidies. Now, in India, every year about 500,000 children are born with congenital anomalies, and most of them are chromosomal or genetic aberrations. The commonest is Down syndrome, and about 21,000 babies are born every year with Down syndrome, which means about 20,000 gynecologists in the country every year. Every gynecologist has at least one baby born with Downs. In addition to that, there are several other genetic syndromes, thalassemia major being the commonest, followed by sickle cell disease, spinal muscular atrophy, and so on and so forth. And these chromosomal and genetic problems are a huge burden on the society with respect to healthcare and financially as well, right? And of course, to the family, it is quite distressful to bring up a child with disabilities. So looking at aneuploidies, diagnosis and screening. Now, Down syndrome, as I already told you, is one of the commonest non-inherited form of mental challenges. And a diagnostic test for any chromosomal abnormality or a genetic abnormality is only possible by doing an invasive test, because we need a fetal sample to confirm the diagnosis in the fetus. So any diagnosis that needs to be confirmed must have an invasive test, a fetal sample, either from the amniotic fluid, which is nothing but the baby's urine, or from the chorionic villus, that is the placenta, which is known as chorionic villus sampling, or sometimes even the fetal blood, which gives us definitive diagnosis. But invasive tests do carry a small risk of miscarriage, and therefore it is to be done only in specific situations with specific indications. Now, looking at the first trimester screening, the first trimester screening primarily comprises of the nuchal translucency scan or the first trimester scan. If you look at the nuchal translucency alone, that is the thickness of the neck, and if it is measured according to the Fetal Medicine Foundation guidelines with proper magnification, with proper placement of the calipers, baby in the neutral position, then the detection rate for just nuchal translucency is about 75%. When we add on the blood parameters, the serum screening, which primarily comprises of free beta HCG and pregnancy associated plasma protein, that is the PAPA, this takes us to a detection rate of 90%. The latest one in the market is the cell-free fetal DNA, or the NIPT, or the non-invasive prenatal test or screening, which has got a much higher detection rate of nearly 98-99% for primarily Down syndrome. So there are a number of tests that are used alone or in combination which can improve the detection rate. Obviously, when you use parameters in combination, the detection rate is much better. For example, if you use only serum screening in the first trimester, which ideally should not be done on its own, gives us a detection rate of only about 65 to 70%. When you add on the nuchal translucency scan with the measurement of the proper measurement of the crown rump length and the nuchal translucency, that improves the detection rate to about 90%. And of course, the NIPT along with the scan, which gives us a 99% detection rate. Now, in the second trimester, similar to the first trimester, which looks primarily for the structure and markers, we have what is known as the mid-trimester anomaly scan, which not only looks for abnormalities in the second trimester, but also looks for markers which could indicate the possibility of a chromosomal abnormality. Now, studies have shown that if you use the anomaly scan alone with nothing else, the detection rate is not so great, and this is primarily because there is varying standards of scans that is being performed in the various places, and what they have quoted is just about 50 to 60%, right? 56% to be precise in the radius study. Now, of course, with the advent of newer markers, particularly with the nuchal edema, the nasal bone, and the aberrant right subclavian artery, this is much improved. When we combine the genetic sonogram with the serum screening in the second trimester, which is primarily a second trimester quadruple test, this detection rate is improved to about 85 to 90%. Of course, the cell-free fetal DNA or the NIPT test can be performed in the second trimester also, which gives us a 99% detection rate. But the best, whether it is in the first trimester or whether it is in the second trimester, is a combined test. And of course, if you combine the first trimester combined with the second trimester combined, that improves the efficacy of the entire test to almost 95%. And this is known as the sequential screening. Okay, so now let's look at the first trimester markers. The first trimester markers are primarily a good crown rump length is very, very important because the nuchal translucency is a function of the crown rump length. So the crown rump length must be measured correctly by proper magnification, right? And you need to have the baby in the neutral position there. You need to have the baby's neck should not be too flexed or too extended, and it should be a good mid-sagittal position. So, and you measure the top and the bottom, and primarily it is the longest length of the baby, longest linear length in the baby. So the crown rump length should be measured correctly because this is also very important for a correct dating of the pregnancy as well. Then come to nuchal translucency. The nuchal translucency is an extremely important marker because in nearly 65 to 70% of babies with chromosomal abnormalities, the nuchal translucency can be increased. Right? Now, the baby has to be in the neutral position with the space between the chin and the upper thorax. That's the space. Now, it's very important that space is seen because that will confirm that the baby is not too flexed where the space is very much reduced, or if it's too extended then the space is much increased. And the baby should be horizontal. So the baby is lying down straight on its back, and you do not see the zygoma there. You see the nice profile, the forehead, the nose bone, the maxilla, the chin, the baby in the neutral position, and just the upper thorax. That's all. And the head should have reached almost the tip of the screen. So this is known as the 75% magnification, which confirms that you have proper magnification of the upper thorax of the baby. The nuchal translucency is measured typically where it is the largest, because you need to give the worst possible scenario to the parents, and where of course it should be, the lines should be clear as well. The nasal bone is seen in the same image. It is seen as 3 white lines. So the nasal bone, the skin and the tip of the nose. So this presence of the nasal bone is very reassuring because it reduces the risk for chromosomal abnormalities. However, the absence of the nasal bone will increase the possibility of chromosomal abnormalities. The other marker is the tricuspid regurgitation, which is checked in the heart. This is the tricuspid valve Doppler. Right now, the heart is seen typically in the apical, is visualized in the apical or the basal position. The calipers are placed across the tricuspid valve and the Doppler waveform is obtained, and you'd see only forward flow across the tricuspid valve and there is no backward flow. If there is backward flow, then that is tricuspid regurgitation, and tricuspid regurgitation is defined as when the velocity is more than 60 centimeters per second and it occupies more than half the cycle. The presence of tricuspid regurgitation increases the possibility of chromosomal abnormalities. The other Doppler that we do is the ductus venosus Doppler. Now, ductus venosus is a small blood vessel which connects the oxygenated blood directly from the placenta into the fetal heart and straight up to the upper body, and it shunts the blood, and it is a very high velocity waveform with only forward flow. Now, the ductus venosus is picked typically in the mid-sagittal view, and at the caliper is placed just within the vessel and the waveform is obtained, and as you see there's a forward flow, and the PI, that is the pulsatility index, is extremely important to check the assess for the risk of chromosomal abnormalities. So an abnormal ductus venosus Doppler, presence of tricuspid regurgitation, increased nuchal translucency, all of them are not only markers for aneuploidies but also markers for cardiac defects, and therefore all these markers must be looked for in the first trimester itself. Along with these markers, when we combine it with the first trimester serum screening test, which includes 4 hormones, that is the free beta HCG, the PAPA, the PLGF, the placental growth factor, and alpha fetoprotein, this improves the detection rate for chromosomal abnormalities. Now let's look at the markers in the second trimester. Again, in the second trimester, there are a number of markers that have been defined by various authors, and one of the meta-analysis in the White Journal in 2013 from Professor Nicolaides' group showed the likelihood of these markers. They are mild ventriculomegaly, where the cerebral ventricles are more than 10 millimeters, the echogenic bowel, the mild renal pylactasia, presence of nuchal edema, the absence of the nasal bone or a hypoplastic nasal bone, and echogenic intracardiac focus. These are all markers for chromosomal abnormalities. Now, the lateral cerebral ventricle more than 10 millimeters, increased nuchal translucency of more than 6 millimeters, echogenic bowel, whether it is present or absent, mild hydronephrosis of about 4 to 5 millimeters, a short femur or a short humerus less than 5th centile, a hypoplastic nasal bone less than 2.5th centile, and presence of aberrant right subclavian artery or EIF. So these are the major markers, and with these presence of these markers will increase the risk for chromosomal abnormalities, and the absence of these markers will reduce the possibility of chromosomal abnormalities. Not only this, if there are more number of markers, then again the possibility goes up significantly. How do we go about once we've had a first trimester risk assessment? So first trimester risk assessment is extremely important for all fetuses. So you do a good first trimester risk assessment, and typically if the risk for chromosomal abnormalities comes less than 1500 and there are no abnormalities in the baby, then we may or may not decide to do a quadruple marker test at 15-16 weeks, but a good anomaly scan at 18 to 20 weeks is very important to check for other structural abnormalities as well. If the risk is more than 1 in 250, you look for anomalies. If there are anomalies, then there is no question that we need to do an invasive test because we need a definitive test. And of course, we must counsel the parents regarding the procedure-related loss of about 1 in 300. Now, if there are no anomalies, but the risk is high, some parents may feel that they would not want to take the risk of the invasive test, that is the risk of miscarriage of a normal pregnancy, and therefore they may want to choose to do the cell-free fetal DNA test. And it is largely reassuring. It's not diagnostic, we must remember that, and we must inform the parents that, but it is largely diagnostic. If it comes back, if the NIPT comes back as high risk, then we must do the invasive, or if it's a low fetal fraction of particularly less than 4%, because then the test is not as good as 99%, then in that case also we must do an invasive test. However, if anomalies are present, we must straight away go and do the invasive test, because we need not just Down syndrome, we need to know about the other chromosomal abnormalities and sometimes even genetic abnormalities as well. In the low risk group, if you find anomalies either on the regular scan or on the anomaly scan, then I think there is no question, we need to go straight and do the invasive test. Then you have a group in between called the intermediate risk or the intermediate zone, from 1 in 251 to 1 in 1500. In this group, it is reasonable to do an early scan to see around 16-17 weeks to see if there's any abnormalities that you can see early enough. And of course, if there are no abnormalities, you may want to offer the parents a better screening test, and that would be in the form of NIPT. Again, if the NIPT comes back as low risk, that is highly reassuring, but if it's high risk or if there's a low fetal fraction, then we will need to do an invasive test. However, if there are anomalies, again, there's no question, we go ahead with the invasive test. So I hope this is clear. Now, at any point of time, if there are fetal abnormalities, one must aim for a definitive test, a diagnostic test, that is an invasive test. However, in the absence of abnormalities, we may buy some time by going the NIPT, because again, vast majority of these babies could be normal, and if the NIPT is low risk, then that would be quite reassuring to the parents. So a structurally normal baby with a low risk NIPT is a very favorable situation to be in. So when it comes to aneuploidies, the first trimester screening is of course the best. The accuracy is the highest. I already told you 90% when you combine the first trimester scan along with your serum screen. And of course, the most important thing is you've got time. You've got time to sort out the problem. And of course, if there is an increased NT, you can watch the NT, see if it resolves or it increases, and then plan the care accordingly. In the absence of anomalies, you add on the serum screening, the first trimester quadruple or the second trimester quadruple, which definitely improves the detection rate. And not only that, the serum screening hormones are markers of placental dysfunction as well. So a very abnormally high or low beta HCG or a PAPA or a low PLGF or a high AFP could be markers of placental dysfunction, and that gives you more information than just aneuploidies as well. However, if there are anomalies or if there are significant markers or if there is a significant history, or if the parents say that you want to do, they want to be absolutely certain, then it is always better to do an invasive test. Now, it is very important to do an invasive test, because if the invasive test results are normal, it is largely reassuring. If it is abnormal, then you would know what is the chances of it happening again, and then we can counsel the parents much better. And importantly, it helps to manage the future pregnancies as well. In certain situations, we need to take a genetic opinion, and this must be kept in mind as well. The earlier we take the genetic opinion, the better, because many of the genetic tests also can take a good 4 to 6 weeks to get the results. And many a times we have to test the parents before we test the fetus as well. So this needs to be borne in mind all the time. Particularly in our country, this is very relevant because we have a large pool of genetic abnormalities, primarily because of marrying within the community and consanguineously as well. So that was aneuploidies. We now move on to the structure of the fetus. The baby is fully formed by 14 weeks. So it is good to assess the anatomy of the baby. The head, the skull, the midline, and the butterfly structure are the choroid plexus. Coming down is the two eye sockets, the back of the baby, the spine, the profile of the baby, the face, the palate and the lips, the bladder, the fetal bladder and the umbilical vessels around it, the two hands, two legs, the heart, the chest, the lungs and the cardia, the abdominal circumference with the presence of the stomach bubble, the umbilical cord insertion, and the cord insertion there again in color as well. So the head, the body, two hands, two legs is all formed. So if there's any major structural problems, we can pick it up at this stage. Now, we did a study at BFMC a few years ago where we targeted 9 abnormalities that is always present in the first trimester and therefore must be picked up in the first trimester. The absence of the skull will confirm acrania. If there is partial opening of the skull and because of which the brain is protruding outside, will confirm encephalocele. And when you see encephalocele, it's very important to have a look at the kidneys and count the fingers as well, because there is a condition called Meckel-Gruber syndrome, which has the triad of an encephalocele, polycystic kidneys, and polydactyly, which has got a recurrence risk of 25% because it's an autosomal recessive condition. So must bear in mind all the time. Alobar holoprosencephaly, because if you don't see the midlines separating the two sides of the brain, then that increases the possibility of alobar holoprosencephaly. Now, at the back of the spine, there's absence of the cervical vertebra, which causes a kind of a stargazing sign for the baby, and that is known as ineancephaly, and it can be detected in the first trimester. Anti-abdominal wall defects, the exomphalos and the gastroschisis, which is basically the defect in the anti-abdominal wall because of which the intestines have come out. If it's contained within a sac, it's an exomphalos. If it's not contained in the sac, then it is gastroschisis. A large bladder, which is more than 7 millimeters, is indicative of megacystis, and if it is more than 15 millimeters is more likely to be an obstruction, but 7 to 15 millimeters is more likely to be a chromosomal abnormality. As I already told you, the limbs are already formed. The two hands and two legs are formed. So it's very important to see all the 3 segments of the upper limb and all the 3 segments of the lower limb at the first trimester scan itself, and it is very easily visualized because most of the times the baby keeps both his hands and fingers open like that, and then so it's easy to look at the 3 segments. And the same thing with the legs. Most of the time they keep their legs up there in the in a typical position, so it's easy to visualize all the 3 segments. And of course the body stalk anomaly, where the half the baby's body is outside the amniotic sac with a short cord which is just hanging off the placenta. So these 9 anomalies, the target 9 or the always detectable 9, must be detected in every first trimester scan. It's good practice to prepare a checklist and put it on your on your scanning machine or on your table till the time you get familiar with this. So now let's look at the anomaly scan. Now the anomaly scan has got various components. It is important to assess the markers, that is the genetic sonogram. We look at the structural defects including the heart. So we screen for cardiac defects and even diagnose cardiac defects in the second trimester. We look at the uterine artery Doppler, which will help us to assess the possibility or the risk of the mom developing high blood pressure problems of preeclampsia and fetal growth restriction. It's important to assess the cervical length, preferably with a transvaginal scan, and this helps to assess the risk for preterm delivery. And of course, look at the placenta, the amniotic fluid, look for the localize the placenta, the vasa previa and the amount of amniotic fluid, and based upon the findings, we arrange follow-up accordingly. Now, the routine anomaly scan is performed at 18 to 19 weeks, primarily because of the law of the land, which does not allow termination beyond 20 weeks. So 18 to 19 weeks, all babies must have a anomaly scan, and we follow up if there are markers, either with an invasive test or a serum screening, or if there are defects. Now, if there are defects, of course, we need to go with invasive. If it's a single defect, then it is reasonable to do karyotyping. If it is multiple defects, then it is better to do a microarray. And of course, remember to store the DNA because it helps to test in the future if there is anything else that comes up there. So DNA storage is a good idea. And if there are abnormalities in the uterine artery Doppler, PI is increased, then we do serial 4-weekly growth scans. At this stage, it's a bit debatable whether we need to give them aspirin or not. And of course, there is also a lot of work going on markers for preeclampsia in the second trimester, which is primarily the placental growth factor and the S-FLIT. Looking at the cervix, check the cervical length, and if it's very short, then there is a role for progesterone and possibly cervical suture, and of course follow up at 23, 24 and 30, 32 weeks as well. Now, this is the routine anomaly scan, but in certain circumstances, as I already told you, we do an early anomaly scan, and the early anomaly scan is done at 16 to 17 weeks, and the indications are primarily a high or an intermediate first trimester, a pre-NIPT, because before NIPT we have to make sure that the baby doesn't have any structural abnormalities. If there's any previous anomalies, then of course it's always good to reassure the parents early. Then of course family history of abnormalities or developing abnormalities, an early anomaly scan which will show that the baby is looking normal will be hugely reassuring to the parents. Particularly if they are very, very anxious as well. When we do an early anomaly scan at 16, 17 weeks, it's good to do the routine anomaly scan, not at 19, 20 weeks, because that's just too early. But if you just push it a little bit forward by 22, 23 weeks, then it gives a good 4 weeks to assess the growth of the baby as well. And of course, the advantage is the sensitivity of the uterine artery Doppler and the cervical length in predicting preeclampsia, growth restriction, or preterm delivery respectively is much better at 23, 24 weeks. So this would be a general plan for your anomaly scan as well. So I hope that helps. So with that, let's move to the next important aspect of the first trimester screening, that is the screening for preeclampsia and fetal growth restriction. Now we know maternal hypertensive disorders is one of the most important causes of maternal mortality in the country, affecting about 2 to 5% of the pregnancies. And there are many women who die because of preeclampsia, which goes undetected or it is detected very late. So screening for preeclampsia in our country is extremely important. There are various parameters in the first trimester that can be used to screen for preeclampsia, and it is very important to screen for preeclampsia in the first trimester because then you can institute interventions which would actually change the course of the disease and make the disease much milder as well. Now, the Fetal Medicine Foundation has looked into various parameters in isolation and in combination, and typically they are the maternal history, that is history of previous pregnancies affected by preeclampsia, the mean arterial pressure, the uterine artery Doppler, the PAP-A levels in the serum, and the PLGF serum levels in the serum, and combination of all these will put you in the green zone. And if you use all these parameters, the detection rate for preeclampsia can be as high as 80 to 90%. If you use only some of the parameters, maybe 2 of the parameters, the detection rate is not as high, maybe at 60, 70%. But if you use them all in isolation, they are really not so good with a detection rate of only about 30 to 40% there. Therefore, a combination of factors, that is the demographic, the maternal demographics, the history, the mean arterial pressure, the uterine artery Doppler, and the PAP-A and PLGF, particularly in the serum, all put together will give us the highest detection rates of about 85 to 90%. The Fetal Medicine Foundation compared these parameters to what has been prescribed from the NICE guidelines, and that clearly shows that if you go only by history, that is as prescribed by the NICE guidelines, then the detection for preeclampsia would be only about 40%, but particularly early preeclampsia, that is preeclampsia developing before 32 weeks. And this can be much improved to 90 to nearly 100% if you combine the factors. For preeclampsia developing between 32 and 37 weeks, the detection rate of only history is about 40%, whereas this can be improved to 80% by combination of factors. And of course, for late preeclampsia, it's not very different. The landmark ASPER study, which was published about 2 years ago, showed that in women who are at high risk for preeclampsia, as suggested by the FMF algorithm of more than 1 in 100. More than 1 in 100 was taken as the cutoff to define women who had increased risk of developing preeclampsia, and they were given aspirin 150 milligrams in the night after food, and they clearly showed that for early preeclampsia there was an 80% drop in the incidence of preeclampsia, whereas for preeclampsia before 37 weeks there was nearly 60% drop, and of course a small non-significant drop for term preeclampsia. So this is very, very important part. So if you screen in the first trimester, use the FMF algorithm appropriately, and then in the women who are at increased risk of developing preeclampsia of more than 1%, you give them aspirin, then the chances of them developing these complications, these dreaded complications, will be much less. Therefore, it is important to screen for preeclampsia and fetal growth restriction in the first trimester. But of course, there will be some women who will miss out on this opportunity, and therefore do we need to screen again for preeclampsia? And the answer is yes. Of course, in the second trimester also we screen for preeclampsia and growth restriction, and at this time it is primarily the mean arterial pressure, the uterine artery Doppler, and the PLGF. And of course in some settings they are using the S-FLIT ratio as well, and this gives us a much higher detection rate for screening for preeclampsia before 34 weeks, also before 37 weeks as well. So the mean arterial pressure, the uterine artery Doppler, and S-FLIT are increased, whereas the PLGF is reduced in pregnancies that are deemed to develop preeclampsia. Do we need to continue screening for preeclampsia? Yes, because preeclampsia can develop at any stage in pregnancy. Even in third trimester, it is important to screen for preeclampsia because you can catch the late preeclampsias and of course the growth restrictions as well. And here you would use the mean arterial pressure and the placental growth factor with the S-FLIT PLGF ratio and the uterine artery Doppler, and it was give us really more than 90% detection rate for early onset preeclampsia. So yes, so you will continue screening for preeclampsia. So what happens if you screen for preeclampsia beyond 20 weeks and they are screen positive? Now at this stage there is evidence to show that there is little benefit from aspirin, but what would be important is to monitor the mother and the fetus very closely, and that will be, with that we will be able to pick up early signs of preeclampsia and growth restriction. Patient education about the symptoms, signs, the fetal movements and delivery care is very important, because with that we motivate the patient to report early if there are any signs of preeclampsia, because we know there can be a lot of overlapping signs of preeclampsia with tension, headaches and visual disturbances being present in other conditions as well. Frequent blood pressure monitoring is very important. Because routinely they would go monthly for their checkups and every fortnightly and then weekly, and that may not be enough. And therefore in women who are at high risk of preeclampsia after 20 weeks, they need to be monitored every fortnightly and then every week, and maybe even more frequently in the week with their blood pressure. And of course you can do home monitoring with the automated systems that is readily available these days. And of course, for monitoring for fetal growth restriction is by serial scans. If all is well, the baby is growing well, the mother is well, 4 weekly scans are good enough. If there is any parameters that is more or less, like the AC is a little bit less or the amniotic fluid volume is less, then you would monitor them every 3 weeks. And of course, if there is any Doppler anomaly, it can become every weekly or every fortnightly as well. So this is screening and follow-up for preeclampsia and fetal growth restriction. So now I move to the next section, which is on preterm delivery. Now preterm delivery is a very, very important aspect, because when babies are born preterm, it causes a lot of not just mortality for the baby, but also long-term morbidity for the baby. And babies that have spent long time in the NICU can have problems in the neonatal period, the infant period, and in the childhood and adulthood as well. So it's very important to minimize preterm deliveries in every possible way, whether it is iatrogenic or whether it is spontaneous. One of the primary methods of screening for preeclampsia is measuring the cervical length, and the cervical length typically is measured with the transvaginal scan in the first trimester, second trimester, or third trimester. Of course, in a woman who has had previous preterm delivery, it is important to check it early as well. However, in a routine setting, if there are no previous history of preterm deliveries, it is not unreasonable to check the cervical length in mid-trimester, and if there are any signs of shortening or if there is any other problems, then they can be monitored more frequently. Of course, in situation like twins, or if there is polyhydramnios, if she's got abdominal pain, we need to check for the cervical length as well. That will give us a better assessment as to whether it is indeed preterm delivery that is causing all these problems or not, or whether these problems are leading to possibility of a preterm delivery. Now again, there are a lot of studies which have looked at routine screening by cervical length in the low risk versus the high risk population. They have used cervical suture versus progesterone, and progesterone has definitely shown a marked improvement in the outcomes, especially when used transvaginal, the micronized progesterone 200 milligrams in women with short cervix of less than 15 millimeters. Then in threatened preterm labor, if the cervical length is less than 15 millimeters, giving them a shot of steroids would be useful, because then the risk of preterm delivery in the next couple of weeks is highest. However, a long cervix, a cervix which is more than 25 millimeters in women who have threatened preterm labor, is very reassuring that it is unlikely that this woman is going to deliver. So if you are controlling the contractions and the cervical length is long, then it's unlikely that she's going to deliver preterm. Cervical length at 22 weeks and very early preterm, the shorter the cervix, the chances of delivering early increases. Ideally, the cervical length should be checked with the transvaginal scan, and this is a short cervix which shows that the sac has completely prolapsed into the cervix and the residual cervical length is only that much, and of course that is quite shortened as well, right? So, and this will increase the risk of preterm delivery. So the shorter the cervix, the risk of preterm delivery goes up higher. So let's look at the prevention of premature birth in women with short cervix. And typically short cervix is defined as 15 millimeters or less, which increases the risk of preterm delivery. So a study by my dear friend Eduardo de Fonseca at Fetal Medicine Foundation clearly showed that the progesterone is superior to placebo in reducing the preterm delivery rate by over 40%. Now, if the shorter the cervix, the higher is the risk of preterm delivery, and the implications are that we do routine screening at 20 to 24 weeks, and if the cervix is less than 15 millimeters but between 10 and 15 millimeters, treatment with progesterone. If it is between 16 to 25 millimeters, a little bit on the borderline, then also maybe a treatment with progesterone may be indicated in some cases. However, when it was 1 to 10 millimeters, it was not as effective as it was in the group which had 10 to 15 millimeters. So that is really short cervix. So this requires further research, but it typically in this group will be the one which is most difficult to put the suture as well, right? So there's a lot of studies going on across the world to look into these specific areas. So this is about prematurity and preterm delivery. With this, we will move to the next very important aspect of the first trimester scan, and that is multiple pregnancy. That means there's more than one baby, and when we know there is more than one baby, there are bound to be complications, more likely than not. So the management of multiple pregnancies really begins in the first trimester itself. It is extremely important to define the chorionicity, that means how many placenta are there, and the amnionicity, that means how many amniotic sacs are there, which is confirmed at the first trimester scan. When there is more than one baby, there are risk of preterm deliveries increased. And with twins, it goes up to 10%, whereas with singleton is about 2%. With triplets is about 25%, goes to 50% with quadruplets, and quintuplets much, much higher. And therefore, the procedure called fetal reduction came into practice to reduce the complications of prematurity. In addition, if you have monochorionic, that means they share the placenta, you can have problems which is specific to monochorionicity, like the twin-twin transfusion syndrome, or the selective fetal growth restriction, or the twin anemia polycythemia syndrome, that need to be monitored from 16 weeks. And this is typically by every 2 weekly scans if there is no discrepancies. However, if there is discrepancy, that means one baby is small, one baby is big, or a sac is small, sac is big. If there is a difference between the two, then it must be weekly scans and refer to a fetal medicine center who will look after these babies more closely and more specifically. Now, in dichorionic and monochorionic twins, the chances of cardiac abnormalities is relatively higher, and therefore an anomaly scan and a fetal echo scan at 18 to 20 weeks is a very good idea. If it's a dichorionic twin pregnancy, then serial growth scans from 26 weeks, 4 weekly scans if there is no discrepancy, and 1 to 3 weekly depending upon what is discrepant there really, and what are the other situations that is dictating the management of that pregnancy. Of course, if there are no complications, it's very important to take them to term and deliver them at 38, 39 weeks by either a cesarean section, and in some circumstances, some doctors would prefer to do a vaginal delivery if there are no contraindications. So yes, that is decided case to case basis, right? So with this, we need to know that can we really bring about best outcomes for the mother and the baby? And we believe that yes, we can optimize the antenatal care by structuring it, by triaging the fetuses in the first trimester into high risk and low risk, and keep changing the risk factors as the pregnancy goes along. But triaging in the first trimester is extremely important. It's very important that we provide accurate information to the parents to be able to handle situations where there is likelihood of abnormalities, and very importantly, facilitate the delivery in an optimal environment. Particularly if there are fetal problems, they need to be delivered in tertiary care centers, and this can be structured in the antenatal care itself. To summarize, the early pregnancy scan, which is typically performed at 7 to 9 weeks, looking at the viability, the location of the pregnancy, and the chorionicity. The first trimester scan at 11 to 13 plus 6 weeks, looking at the viability. If there is more than one fetus, check the chorionicity and amnionicity, and this is the best time to do that. Screening for aneuploidies, screening and diagnosis of structural defects, and screening for preeclampsia and growth restriction. We can add the serum markers in the first trimester, and typically that would be the first trimester quadruple test. The second trimester anomaly scan at 18 to 19 weeks, looking at the growth of the baby, the amniotic fluid in the placenta, the fetal structural survey, the genetic sonogram, the uterine artery Doppler, and the cervical length. And we can add the second trimester quadruple marker test to this scenario, which will improve the efficacy of screening for chromosomal abnormalities. A routine growth scan. In my opinion, a routine growth scan at 30 to 34 weeks is good, because it not only will pick up the last few of the early growth restrictions, but also it will pick up the first few of the late growth restrictions which are developing. 1. 2. There are certain in utero anomalies that could be developing, which can be picked up at 30 to 34 weeks, and you can do a good late anomaly scan as well. So if there is anything that is developing later on in pregnancy, you have got enough time to sort it out as well. So 30 to 34 weeks is a good window to do your follow-up routine growth scans. And of course, in certain situations, you need to follow up, like in twins or diabetes or preeclampsia, certain other situations, you need to follow up, you need to prepare a follow-up plan accordingly. Now, this will ensure that we have a good outcome for the pregnancy with a healthy baby and a healthy mom at the end of it, because we strongly believe that every fetus deserves to be screened for all possible complications, right? And this is something that we owe it to the fetus to optimize the care of the fetus. And I hope you found this talk useful, and I would be looking forward to your comments and your suggestions. And thank you very much. Indeed.